Okay, thank you, Dorcas. I think we'd better move on to the last case presentation of the day. This is on Zika virus, and it's going to be given by Ricardo Palacios Gomez from the Butantan Institute in Brazil. Ricardo.
Thank you very much for the organizers to allow me to present these considerations on the Zika virus human challenge study on behalf of my fellow colleagues, Sima Shah and Ed Reid. So this presentation, I will start with a little bit of background on Zika virus, and then I will comment on the Zika virus human challenge consultation process that was convened by NIH. So Zika virus is an old virus, so it's not a brand new, as probably is brand new for many of us because we never studied it so deeply. And the reason why is because this virus was not pathogenic when it was discovered in the Zika forest in Uganda in the 1950s. And so that is the reason because nobody took so many care about it. And in the next decades, there were some few cases in rural areas in Asia. And again, it was a very mild virus without very few symptoms. And the first warning was in the early this century in the Yap Island in Micronesia, where it was reported the first outbreak in the population outside of Africa. And this outbreak was not important because of the clinical feature of the disease, but because the extension of the outbreak. They consider that this outbreak infected about the half of the population of the island. Then, 6 years later, in 2013, 2014, the virus arrived to French Polynesia. And one of the differences in the French Polynesia outbreak is that the virus arrived to a place with a very dense human population. So there were a lot of people in a small space. They would have also the vector in these urban areas in French Polynesia. So probably it triggers the genetic transformation of the virus. And out of this, we start to see very unusual symptoms that were related to this virus. First warning was the Guillain-Barré, and then we saw the jump to Brazil when we actually get the emergency. So we see in a timeline, the first point when we really get a problem, is here, is a patient with Guillain-Barré in Micronesia, in Polynesia, and then we have the cases in Brazil of microcephaly. It doesn't mean that the microcephaly occurs by the very first time in Brazil. Right now, we know that the answer is no. And the reason, because we didn't realize that in French Polynesia we had microcephaly and other congenital syndrome related to Zika, is because the ladies, pregnant ladies in French Polynesia get very good prenatal care, and they had access to legal abortion. So many of those babies that with malformations in French Polynesia actually never get born because the pregnancy was interrupted before they have the delivery. So that's the reason, because we never noticed that the Zika was causing this congenital syndrome in the French Polynesia cases. However, in our countries in Latin America, where most of the laws forbidden the abortion, where the prenatal care is not that good, ladies get knowledgeable about their pregnancy very late. So the opportunity for having an early diagnosis and having the interruption of the pregnancy, it was not available. That's the reason, because we saw this huge outbreak. So at the beginning in Brazil, the news about the disease didn't came from the medical, the medical journals or something like that, or even this from surveillance from the Ministry of Health or Secretaries of Health of the states. It came from the journals, the newspapers, because the disease was so mild that nobody paid attention. I could say very sure about it that we had millions of people infected in Brazil before we get a notice what is going on. So it was kind of a mild dengue. It's one of the news. It's like a kind of a mild dengue, and there was a misdiagnosis with a milder strain of dengue, and it was only later that we realized that it was a new virus. So currently, this is the distribution of Zika. So we can see here in Latin America, we have these areas where we have the transmission still in low scale. We have some areas in Southeast Asia and still in Africa. So the first association with a relevant condition in Brazil, as well as in French Polynesia, was the Guillain-Barré. So we realized that it was Zika, the cause of this mild disease, in June 2015, and we learned about the cases of Guillain-Barré only by October. Then we, about that time in October, they started the births of the babies with the malformation associated to Zika, mainly microcephaly. So we can see here where the time of the outbreak of clinical cases, and here when the cases of congenital malformations arise. So this time gap corresponds to the pregnancy period. So what we do now about Zika virus? Zika virus is a flavivirus. It's related to other flavivirus, mainly to dengue virus. So it's here in the family. There are the main member of the family, the yellow fever virus. There are others that probably you are familiar with Nile, Japanese encephalitis, St. Louis encephalitis, and tick-borne disease. And it's transmitted by the mosquito Aedes. And what we know is that is the main way of transmission. We have also this knowledge about the maternal fetal transmission, and this is something that is very unusual for flaviviruses. But this one was a brand new way of transmission for flaviviruses that we thought that was mainly by mosquitoes, and this one was by sex, by sexual relationships, because of the presence of the virus in the body fluids. And also there are reports of blood product transfusion, organ transplant, and some cases of laboratory accidents. So what is the clinical features of Zika? It's, in most of the cases, nothing. So about 3/4 of the population to 5 to out of 4 out of 5 % of the population that get infected never notice. And even among those that had asymptomatic infection, they could transmit to other people, and if they are pregnant, they can transmit to the fetus. So this is very important, the asymptomatic cases for the keeping the transmission ongoing. When it occurs, usually it's a very low-grade fever, and the main features are a pruritic rash. That is very important. Here is not that easy to see. The conjunctivitis, so usually this is the clinical feature. You see people with rash, mild fever, conjunctivitis. Some of them, they have also a mild arthritis. And this is the clinical feature of any regular Zika patient with symptoms. In a small proportion of cases, we will have Guillain-Barré. And the difference in the Guillain-Barré of Zika with other Guillain-Barré that we know is that usually is very close to the time of the symptoms or to the time to the infections. In the other cases, Guillain-Barré is afterwards. And the main problem caused by Zika is what we know is called the congenital Zika syndrome. So it's not only the microcephaly, but a lot of problems related to the malformation of the children. So we will have intracranial calcification just like this. So there are some malformations in the brain, in the bones, and also this calcification inside the brain. There are some deficits in vision and hearing. So in some milder cases, probably the newborn looks pretty normal, but after all, we see that there are some deficits in vision and hearing. And the other thing that we have seen is what we call arthrogryposis, that is this kind of malformation in the joints that occur in some of the cases. And usually the risk is higher if the infection is during the first trimester, but it might occur also in malformation, usually mild malformation like vision and hearing deficits, and in the late pregnancy. So there is a risk during all the pregnancy. So we have several gaps. This is a brand new disease in this presentation. This is the Zika that we know from French Polynesia and Latin America is not the same that we learned from Africa. So this is a brand new disease. And we have some questions regarding other ways of transmission like breast milk, confirmation of this transplantation in organ tissue. We have only anecdotal reports. But this is one of the most key points, is how long the people are infectious. Usually when people get infected by a flavivirus like dengue or even yellow fever, the people get infected, get the symptoms or not, and then clear the virus. What we saw in Zika is that some people fail to clear the virus. And apparently, this failure to clear the virus leads to the transmission by body fluids, so it leads to sexual transmission, and it might also relate it to the maternal fetal transmission. So this is really critical for transmission. The longer term effects, there are some doubts, particularly in male fertility, if it might affect or not, because it has been proven that there is infection of the testes. So we need to learn a little bit better about the spectrum of the disease, the rate of complication, and this is interesting because it seems to be that it's changing. So the burden of the disease in Brazil when it arrives to Latin America is much higher than in other countries of Latin America, and even inside Brazil we have some states that had a heavier rate of complications than other states. So we really don't know if there is any kind of cofactor or something that might affect how the disease occurs. And there is other controversy about how the previous exposure to other flavivirus or the posterior exposure to other flavivirus might be affect the clinical disease. So NIH and the Walter Reed Army Institute of Research proposed to have a consultation in order to assess a couple of proposals of Zika virus human challenge trials. And this idea was very interesting because there is a lot of interest in Zika at that time and by the end of 2015 due to the emergency that was declared for public health and the potential of how this infection challenge research could lead to new knowledge, valuable knowledge on the pathogenesis and for selection of vaccine candidates to move forward to later phases. So what NIH asked the consultation group was, can a Zika virus human challenge trial be ethically justified? And if so, under what conditions? So they convened an independent writing committee, and for this committee, the criteria to get in was independence from funding and reviewing agency, not planning to conduct a Zika virus human challenge trial, and relevant cross-disciplinary expertise, either in research ethics, gynecology, neurology, and experience with challenge studies. And I was part of this committee, so that's the reason because I want to show you a little bit of the insider discussion. So let's talk a little bit. So we know that there is a lot of controversy on the human challenge study because at the beginning you are calling people to be infected. So this is kind of the opposite of you are calling people for a clinical trial. You are trying to cure or control a disease. But in this case, you are calling people to get infected. So this is kind of the opposite of what you expect. So they are very, very controversial. And so we decide to choose some of ethical considerations that are applicable not only for Zika, but I guess for many other controlled human infection models. So first one was, are risks and discomforts identified, minimized, determined to be reasonable and justified by social value? The second was, is scientific, rational, and social value acceptable? The third one is there a system for compensation for research-related injuries? Are vulnerable population enrolled? Is informed consent process adequate? Is level of compensation adequate or undue? Can right to withdraw be respected? And will appropriate community engagement occur? So I will, of course, I can take a lot of time discussing all of these 8 points, but I will focus only in the first one. So when we talk about the risk, we always think in the risk in this kind of setting in a way that, you know, we should minimize, you should have something reasonable. But if you think about risk outside of this setting, you can see that the people take very crazy risks for any different reasons. I stopped to turn on the TV because there are a lot of TV shows showing crazy people going around, dropping in the jungle, and putting themselves in a lot of risk. And it's kind of crazy why the people and the motivation to do so are not like so socially valuable, like making the advancement in the understanding of a pathogenesis of selecting vaccine candidates. So, of course, it's like we don't have a limitation of the risk outside of the research environment, but there is a questioning, and okay, why not let people do what they want? If they really understand the risk, why you don't allow these people to move forward? Yeah, of course, for us it's not that easy. For a probably TV show producer, it could be quite easy, but for us it's not, because we understand what the risk is meaning. So, in terms of what is the meaning of this risk, we need consider two parts. One is the risk for the volunteer by himself or herself, and also the risk for third parties. And I would like to emphasize the second part. In the first part, of course, there is not a clear consensus about what is the level of risk that is acceptable. So the consent is the way that we present the risk, has been very studied in research ethics, but I don't hear about any level of higher risk that is acceptable for studies. But on the other hand, we have very few information about third-party risk in the literature. And the problem is that when we talk about third-party risk, we are talking about bystanders that are not informed about the risk. So they cannot just accept or not because they are unaware about the risk. And there are even some risks that we don't know. We don't know in advance. So we need to talk, when we are talking about shame, we need to talk about risk limits. And despite it could be a very difficult conversation for lay people, we need to understand whether those risks will bring benefits to the society, it will have some social value. And we also need to preserve the public trust. All of us, we have the experience when we talk about experimentation in human beings, that we are talking, lay people talk about guinea pigs. So if we don't preserve this public trust, we probably will have a lot of troubles in order to move forward in this kind of studies. So, because in this case, we are infecting people. So we need to be very careful in preserve this public trust and get this institutional support. Otherwise, the people will not want to, the scientists to move in this field. And this is something that could cut the funds for this kind of research if we don't have the public trust. So there are some agreements that okay, it should not be too high, but what usually they say is it's better if the disease or the infectious agent is treatable, it has antibiotic, or like we saw in the previous cases, or is self-limited, and there is no risk of irreversible harm. So there are the kind of the two consensus that we have. But there is some limited argument for this risk limit. So there is only very few information and reflection on that. So
Ricardo, can you try and wrap up in the next couple of minutes?
Sure. So how we can determine when this risk is too high is, so probably we can extrapolate from other disease, like other kind of study, like phase 1 studies. So it's one of the way. So in the risk comparison with Zika virus, we know that this is a very mild disease. The serious adverse events are rare. But the risk to the others appears to be higher than usual. And that is one of the reasons. So that to have this problem. So let me. So there are some approaches to minimize the risk. So for example, we know for an epidemiological studies, what are the people at more higher risk to Guillain-Barré syndrome? So it's to avoid those people. But for risk for the others, it's a little bit more unclear how we can make this protection. There are several ideas like, well, if you have a male participant, how do you avoid that this male had sexual relationship with somebody and get the other people get contaminated and so on. So it's a little bit more difficult, but it's something that we need to think about it. So we know that Zika virus is very important with the potential devastating consequence, mainly for the newborns. And we need a vaccine. We urgently need a vaccine, and the challenge study can help us to reach this goal. So, but the knowledge, and this is something that when you feel the urgency of moving forward, we need to stop by and think about this risk. And what we realize in the committee is that at that moment, we don't have the full set of information to move forward to this human challenge trial. Probably at this moment, we will have more information and we can review this recommendation. So this is the full report. I would recommend you to read it. It's a very comprehensive document that is available. And I leave you with some open questions for you to discuss. Thank you very much.